NURS 252 Pathology, Section 3, Cell Death and Aging. The overview. Welcome to your third section in pathology. In this session, we will illustrate the morphology and explain the mechanisms and features of irreversible cell injury or cell death. You'll be introduced to the types of cell death and the changes that may occur after cell death, including accumulation of substances inside and outside cells. You will practice definitions, terms, listing examples, and providing explanations. The objective of this session, at the end of the session, you should be able to identify the vital systems affected by lethal cell injury and explain the concept of cell death. Describe the morphologic changes of cell death. Distinguish between morphologic types of necrosis. Discuss abnormal accumulations and explain mechanisms involved in various types of cell death. We would treat this section under three topics: irreversible injury and cell death, necrosis and apoptosis, and abnormal accumulations and aging. Your reading for this session can be found in Pathologic Basis of Disease by Robbins and Cotran, 8th edition, 2010, chapter 1. Irreversible injury and cell death. Cell death is irreversible loss of integrated cell function. This can be identified under the light microscope, where there is severe swelling of mitochondria, lysosomes, damage to membranes, and amorphous densities in the mitochondrial matrix. The lysosomes show ruptured membranes, and they release enzymes which digests components of the cell. The process of digestion of components of cells is called autolysis. Under the light microscope, the most reliable features are seen in the nucleus of cells. Three changes characterize necrosis or cell death in the nucleus. 1. Pycnosis. 2. Karyorrhexis. 3. Karyolysis. The cytoplasm also undergoes changes, largely eosinophilia and vacuolation, but these are less reliable. What are the morphologic types of cell death? There are two morphologic types: necrosis and apoptosis. Necrosis is defined as death of contiguous cells in living tissue. It is always pathologic and follows irreversible injury. The changes that are seen are due to two concurrent processes. One is enzymatic digestion, and two is the denaturation of proteins. Depending on the two, which of the two is predominant, two basic patterns of necrosis are seen: coagulative necrosis and liquefactive necrosis. Coagulative necrosis represents denaturation, and liquefactive necrosis represents enzymatic digestion. So now let's take them one after the other. Coagulative necrosis. This is the commonest type of necrosis, and its causes include ischemia, which is the sudden cessation of blood flow. Bacteria, toxins, and chemicals can also cause coagulative necrosis. The appearance of coagulative necrosis under the microscope is characterized by preservation of cell shape and tissue architecture. So you rely on the nuclei to tell us whether there is coagulative necrosis or not. The nuclei may show pycnosis, karyolysis, or karyorrhexis. And this diagram shows how the nuclear changes look like. So the normal cell is there, and then you have pycnosis, where the nucleus becomes small, dense, and hyperstaining. Karyorrhexis is when it fragments, and karyolysis is when it disappears or fades. The other type of necrosis is liquefactive necrosis, also called collicative. This is when there is degradation of the tissue by enzymes, so it rapidly becomes soft and liquefied. It is characteristic of brain tissue when there is ischemic necrosis. In trauma, liquefaction may also occur in the brain. Elsewhere, bacterial infections can lead to liquefaction because of accumulation of polymorphs. And the enzymes from these polymorphs are the source of the liquefaction. Now let's talk about the distinctive types of necrosis. The first one is caseous necrosis. This is where we see necrosis that resembles dry cheese, and you find it in tuberculosis. Some fungal infections also show caseous necrosis. Gangrenous necrosis is when there is necrosis with putrefaction. In dry gangrene, you have gradual arterial or small vessel occlusion, and then you get coagulative necrosis. With time, a line of demarcation appears between the area of necrosis and the viable tissue, and the area of necrosis looks dark. You find this in diabetics when they get gangrene called diabetic gangrene. And then there is wet gangrene, when liquefatic necrosis predominates, such as in gangrenous appendicitis. Again, the organ may look dark. Fibrinal necrosis is seen in malignant hypertension, where small blood vessels show deposition of fibrin. Enzymatic fat necrosis occurs either due to direct trauma to adipose tissue or enzymatic release. Traumatic fat necrosis is seen in the breast, and enzymatic necrosis is seen in pancreatitis. The presence of necrotic tissue usually invokes an inflammatory reaction independent of the stimulus that caused the necrosis. So for whatever reason that necrosis occurs, inflammation comes next to the area of necrosis. Outcomes of necrosis. Depending on the tissue or organ involved, the extent of necrosis and the functional reserve of the organ, and the capacity of the surviving cells to proliferate and replace lost cells, various scenarios may occur. First one is resolution. This is when the necrotic area is restored to normal. It's more likely when the tissue present there are capable of regeneration. For instance, the liver. It may regenerate, but the heart cannot. So resolution can occur in hepatocytes. The next one is organization, where you replace the necrotic tissue by fibrous tissue. The next type of cell death is apoptosis. This is death of individual cells. Again, it may be physiologic or pathologic. The process of apoptosis requires energy. The cell degrades its own DNA and fragments into small bodies called apoptotic bodies. The cell membrane of an apoptotic body are intact and they don't allow lytic enzymes to escape. They are also phagocytosed quickly because the membranes are altered and tagged to make phagocytosis easy. So there's no accompanying inflammation, unlike necrosis that leaks enzymes and there's a lot of inflammation around. Necrosis and apoptosis may coexist and may even be caused by the same injurious agent. It depends on the cell, the degree of injury, and many factors. Causes of apoptosis. Physiologic causes occur in programmed cell destruction in embryogenesis, for instance, how the tadpole loses its tail to become a frog is due to apoptosis. Also, the uterus, which involutes after delivery, does so through apoptosis. The breast after lactation is similar. Pathologic apoptosis occurs due to DNA damage, for instance, from radiation, anti-cancer drugs. It may also be due to infections. Now, how does the apoptotic cell look like? Morphology. There is loss of specialized structures on the surface of the cell. The cell becomes isolated from viable neighbors and then it shrinks and eventually shows changes that are similar to some of the ones we've described before. For instance, the nuclear changes, the chromatin becomes condensed and breaks up into several fragments. But these fragments become membrane bound, and we call these fragments apoptotic bodies. Viable neighboring cells and macrophages swiftly recognize the apoptotic cell and the apoptotic bodies, and they phagocytose them. This table lists features of apoptosis and necrosis, so we can distinguish them. Key ones among them is that there's no inflammation in apoptosis, whereas necrosis is always accompanied by inflammation. Now we come to abnormal accumulations and aging. Abnormal amounts of various substances can accumulate in cells as a manifestation of metabolic derangement. These include water, lipids, protein, carbohydrates, and others. Some abnormal substances may come from outside the body, like mineral dusts, infectious agents, and then others may be synthesized in the body as endogenous abnormal material, and they can accumulate in cells. So let's take the first example, Harlan change. This is glassy eosinophilic homogeneous appearance of a cell or tissue on hematoxylin and eosin sections. And the material could be fibrin or amyloid or other. Intracell proteinaceous materials include Russell bodies, Mallory's Harlan, whilst the extracell Harlan include amyloid or sometimes degeneration of smooth muscle tumor, old scars, or changes in the vessel in hypertension and diabetes called hyaline arteriolosclerosis. Glycogen may accumulate in certain conditions, and then pigment may also accumulate. Exogenous pigments include dust of coal, and the disease that is associated with this is called pneumoconiosis. When there's tattooing, exogenous pigment is usually deposited and is also can accumulate in cells. Endogenous pigments include lipofuscin, melanin, and hemosiderin. Sometimes calcium accumulates abnormally, and we call it pathologic calcification. There are two types, dystrophic and metastatic. Dystrophic is when the calcium deposits when the tissue or cell is damaged or dead. Metastatic is when you deposit calcium in otherwise undamaged tissue due to raised levels of circulating calcium. You can see this in hyperthyroidism, hypervitaminosis D, sarcoidosis, and other such conditions. Now let's move on to aging. Aging is a process that begins with conception. It involves differentiation and maturation of organism and cells, and invariably at some point in time leads to progressive loss of functional capacity, characterized by senescence, and then it ends in death. With age, there are physiological and structural changes in all organs, and the mechanisms of homeostasis slow down. Factors that affect aging in individuals and life expectancy include genetic factors and environmental factors. There are some families where long life is the usual, and it has been found that some identical twins live to about the same age, despite not living in the same area or even communicating with each other. Environmental factors like diet and consumption and inhalation of harmful substances can shorten life. And then we know about lifestyle conditions like alcohol abuse and smoking. They can reduce life expectancy. Then there are diseases that are more common in the aged, and they can also reduce lifespan. Aging is closely related to alterations in cells that result from accumulation of years of sublethal injury. So the cell gradually has a diminished capacity to respond to injury. And it may also be linked to progressive decline in the viability due to genetic abnormalities that accumulate. So there are theories, since the exact reason for aging is not known. The experimental cellular senescence is one of the theories that was propounded based on the finding that fibroblasts replicate up to about 50 populations, doublings, and then stop for inexplicable reasons. That has now been shown to be probably linked to telomere shortening. Telomeres are portions of the chromosome near the ends. So enzymes associated with keeping this portion workable deteriorate with time. The other theory is genetic control, which says that there are genes that control the rate of aging. The other theories have been propounded based on findings in certain diseases where there is accelerated aging process or premature aging. These conditions include progeria and Werner syndrome. Then there is the oxidative stress hypothesis, which says aging is due in part to progressive and reversible oxidative molecular damage to cells. So it is the molecular changes due to oxygen-free radicals that are generated during metabolism that account for aging. There are supports for all these theories in various experimental models, but none of them totally explains aging. The other ones are hormonal decline, that the gradual loss of hormones with age is what causes aging. Then defective host defense, immune responses to mycobacterial agents are impaired with aging. And then failure to renew. There is accumulation of senescent cells without renewal of lost cells. Despite all these theories, the truth is no single theory explains everything about aging. What are the changes in the organs that we see, however? We see in the cardiovascular system changes like atherosclerosis, brown atrophy of the heart, and loss of elastic tissue. In the brain, we find atrophy, like the picture we showed earlier. In the musculoskeletal system, there is loss of bone mass called osteoporosis, and then fractures and muscle degeneration. The eyes, cataracts form, and there are vascular changes in the retina. Hearing loss occurs, the immune system fails, and people become more prone to cancers. 80% of cancers occur after 50 years. So cancer is related to aging. The reference for this session is Pathologic Basis of Disease by Robbins and Cotran, 8th edition, chapter 1.